are a cohort of patients that every medical group or community health center or individual small or solo practice struggles with. We traditionally call those patients attributed but not seen. What I like to refer to that is people who are medically homeless, meaning they don't know that they belong to a team that can take care of them. Let's say they don't know that they're assigned to a medical home and they continue to go to urgent care or the ER. That's data that we can see due to claims, due to other data streams. Let me give you a really good example of this. We had a patient recently who had moved counties in California. One of our healthcare liaisons who effectively functioned like a community health worker did an outreach call, and she picked up the phone and she said, "Oh my goodness, I had no idea I had a doctor assigned to me." And we were able to get her in with kind of a relationship with a healthcare team that could begin to meet all of her needs and even anticipate some of her needs in ways that I think are beautiful and magical, and it's the reason why we do this work. I remember the days when we were doing quality improvement and receiving huge Excel files that were not searchable and really not usable. We're trying to move us from what I would call data-rich, information-poor, or DRIP, to a system where we're data-rich and information-rich. And I think Arcadia has allowed us to have that conversation amongst the clinical leaders and certainly for the downstream clinical teams. The end result is that we get some really beautiful results to the point where in one of our recent years, we closed 44,000 gaps, which is unheard of. I'd never been able to do that in my career. And as a result, we've been one of the top performing IPAs, in this case, were classified as such in the state of California. It's been really cool to see that the response year over year, where health plans continue to ratchet up what those bars are for achievement, and year over year we've been able to create success because there's this culture of wanting to continually improve. This chassis that we've built on fee-for-service is not meeting patients' needs. It's also not meeting physician needs, right? And clinical team needs. Back in the day, before we had hospitals and medical office buildings where people had to go to, what did your family doctor do? What did the country doctor do? They'd go to your home, right? They would go there, they'd understand your social setting, they'd understand your family. When we're focused on value-based care, what it means is that the doctors can spend more time with their patients, and there's a lot of work that can be done in between visits because we're not sort of beholden to needing to see the patient in front of us in the office at that time. We can use data to identify those needs in what I would call the interstitial spaces between visits for us to be able to impact their health. We've had several dozen patients that have, because of the data that's that we've been able to look at in Arcadia, that we've identified that deserve that outreach. Every human deserves the best health that they can achieve. Some of that comes from the healthcare that we provide, but a big piece of that is that caring spirit that we bring to the work and that sense of connection that we have with each other that I feel like is missing a lot in today's world. We can bring that spirit into the world and have it be data-driven all in the same breath.